And I need to move to here. So, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko te tea te maunga, ko o wanaka te roto, ko tamaroa te waka, ko te whānau ina rangi te hapu, ko Waterworth taku ingawa whānau, no Otipoti aho te takapuna taku kainga, ko Kate taku ingawa. No rewa, tēnā koutou, tēnā tātou katoa. So hello, kia ora everybody, talofa lava, namaste. Thank you so much for the invitation to speak at your Lunch and Learn session for the Paediatric Society, and to Jane Hamer for inviting me. My name's Kate Waterworth. I'm originally from the South Island, but have been living here in Auckland for a number of years now. I live here with my husband Diego and my son here, Samuel. On his Mother's Day card, he wrote that he likes to go walking with mummy. So you can see up the top of us at the top of a big hill there, although he wasn't saying that he liked it when we were going up this one. I grew up in Dunedin. I trained as a physiotherapist at Otago, and my first job as a physiotherapist was at the Waitakere Child Development Service. So hello to all of the colleagues, and especially Shirley and Julie, if they're in the audience, who employed me for my first job 20 or so years ago. And for the ongoing learning and provocation that those jobs have offered me. While I was working, I really enjoyed the relationships that I had with the children that I was working with and their families in whānau. Right though, as a new graduate, I felt really confronted by the poverty and the violence that some of those kids and mums experienced. But also there felt to be a disconnection to what was intended from the physiotherapy service that I offered, that my teams offered, and what seemed important and meaningful to those kids and families. I left the job, went travelling, and looked at these, noticed different ways of understanding and living in the world, and then returned to study initially at AUT University, studying the sociology of childhood and children's rights, and moved into a sort of child advocacy space with a group called Action for Children and Youth Aotearoa. I kept a little bit of a clinical role at that stage, but still kept coming up with these kind of bigger questions that I guess we're really thinking about what disability might mean. What was the experience of disability? Why did so many disabled people, despite having probably increased access to a variety of services and accommodations, still had difficult or poor outcomes in terms of things like life expectancy, in terms of looking at sort of political participation and things like that. So with these questions, I came to AUT. I began teaching initially as a clinical educator for physiotherapy students, and then teaching within the program, and also began a very long and very slow and quite arduous journey of trying to do a PhD. So today's little speech relates to my PhD. And Jane in particular asked me to leave you with something tangible to translate into your practice. But I'm afraid I'm possibly not able to offer that. And it's more likely that this kind of work, the work that I kind of do, is a little bit unsettling. But hopefully what it can offer is allowing us to ask new questions about the way we go about things. And to recognise that there are different ways of doing everything and anything. There are different ways to explore questions, different ways to go about practice, and we can actually we can create those ourselves. We can also notice how the history of our practices, of our professions, and how philosophy more generally actually make quite an influence of the way that we understand and go about our day-to-day work, the way our services have been established, and what we do, what we think is important. So most of us will be familiar with two quite dominant models of disability. One which is called the medical model, and one of which is called the social model. So I'm going to trace over these two models quickly, because whatever area we're working or living or going about our daily lives, even in the shopping mall or the library, these influence what happens and how these things are done. We can recognise that before these models arose, over the last 100 or so years, the concept of disability didn't exist as such. But there were different religious and social understandings of what having a long-term health condition, for example, might have meant. But most dominant over the last 100 years is the medical model of disability, which has arisen from the biomedicine. So we can see this not just in healthcare services and provision, but also in the way that our education system and school structure is established, and in our social systems, so moving from social welfare to the institutions we have now. But these are all come from this big system called biomedicine. So biomedicine refers to the practices of Western medicine, which is with its emphasis on the biological body. Biomedicine arose during the Enlightenment, so over the last few hundred years. It uses the scientific method to understand and treat ailments of the body. So previously there were different ways to understand and treat the body. We see the doctor becoming really important as a professional and moving their work from being a bedside physician to working in a hospital with a set of other doctors who become increasingly more specialised over time. And professions such as the allied health professions that many of you will be part of, like myself, physiotherapy, developed in parallel with connections to medicine and then to nursing. And our professions, the development of them, the extension of them, the status that we have has been propelled not just by how good we are at doing our job, but also by historical events. Things like the polio epidemic and then around the 1920s, and then the way physiotherapists were able to treat children at that time were really big pushes for our profession as a whole, and also for the development of the subspecialty of paediatric physiotherapy. Things like the World Wars and the way that physiotherapists and occupational or recreational therapists started to work themselves, made themselves a role, working with servicemen, providing exercise and rehabilitation for injuries post the war. So these are big, broad social, political kind of processes that gave our professions a place and some standing within the social system that we live within. So this is a screenshot from a documentary that there's some really interesting documentaries on New Zealand's screen. And this is of a 1970s documentary around treatment that's provided for what they often call handicapped children at that time. And I really recognised myself in the way that I approached physiotherapy practice with children and with families. So looking at the picture, you get the impression that the therapist is the woman with their hands on the baby. They're perhaps doing some assessment kind of procedure, or maybe a treatment process, and their mum is sitting beside them on the floor. So you could say that maybe represents the medical model of disability as it plays out in kind of therapy kind of services. So these different models allow different possibilities. We could say that the medical model of disability, like within medicine, allows diagnosis, it allows identification, it allows categorization, particularly of something that's considered normal and something that might be called pathological or other. It allows a whole set of interventions and becoming more specific over time. It allows exploration and asking of questions and particular set of a type of evidence. It allows an expert professional and the idea that these professionals intervene and treat individual patients. Over time, however, we can look and think that perhaps there's been some unintended consequences of that kind of model, which, however far we might try to move away from, is really embedded in the history of our services and how we go about things. So we can think that particularly this idea of being an individual, of needing to be fixed, of things being normal and abnormal, has led to some consequences to how disabled people are seen as a group, as an individual, and what that means for their political status. So perhaps disability is often considered a negative experience, a bad experience, something that we should be avoided, and something that we should try and ameliorate. in terms of political status of disabled people, there's traditionally been very few mechanisms for disabled people to express their view, to have that taken into account, whichever level that is, whether that's in day-to-day life or within our broader political and governance kind of systems. So we can see that there has been criticisms of that model and of broader social consequences of the philosophy behind biomedicine. So there was a wave of a change in sort of how the world was understood from that kind of biomedical or scientific kind of approach, with a critique of that called social constructionism. So this is really a philosophy in that people shape and create their world. That the world is not fixed in one particular way, but the way that people act in the world shapes the world. So we can see in the from probably the 1950s, the 1960s, internationally, there were big pushes, people in the streets demanding equity. So the Black Civil Rights Movement, the feminist movement, and later the disability rights movement. So particularly during the probably 1970s and 1980s, which has meant that disabled people internationally, within their own local kind of political systems and international conventions, are rights holders. So have rights to, particularly to express their view, to have that taken into account, to be considered as a whole person who has something important to share, no matter how they might share that, whether it's through voice or some other mechanism. So the social model of disability allows things itself. It's a shift from that medical model. It allows us, rather to think of an individual body, to think of social processes, political processes that allow and facilitate participation, or that act as barriers to participation. And it allows the human rights, the legislative process, to work alongside them to support that. But again, there can be critiques of the social model of disability. So perhaps it's really probably two ends of a pole between the biomedical model and the social model. And perhaps some people would suggest that the social model moves away from actually recognising that a body has consequences, has feelings, has emotions that will impact your day-to-day life. And it also does fit with the same model of there being something normal that should be aspired towards, and perhaps inadvertently maintains a focus on impairment. So there might be, what I wanted to use the rest of my time to talk through, is that there are some other ways that we can understand disability, recognising that particularly these last two, and those that have come before that, so religious models, etc., will always be present in our day-to-day lives. But we can perhaps shift the emphasis and perhaps work towards allowing more complexity, more fluidity, and really critique the social and political kind of consequence that's come from suggesting that disability is a bad experience, is something that should be avoided. So we can look to, in New Zealand in particular, to Maturanga Māori, so the Te Ao Māori, the Māori worldview. Recognise that we're treaty partners and that we look at thinking about equity in this kind of space. So I wanted to introduce those who are unfamiliar to this model called whānau hoa, which was developed by Dr. Huhana Hiki and Professor Denise Wilson, and actually some work that they did here at AUT some time ago. So whānau hoa is a model that allows an Indigenous perspective on disability. And really within this, this model, we're looking at a collective unit being the unit of focus rather than individual. It recognises that relationships and collectivity are really important, and the strength of the collective are important. So for example, if the whānau or the unit was able to meet all of the needs for health within that unit, there would not be impairment or disability. So it might be that I, within that unit, had a health condition that meant that I was unable to participate in a particular role. Maybe I wouldn't be able to participate in a caregiving role, for example, but if that need for caregiving was met within the unit, then the unit would not be disabled. So that's quite a shift from these other two perspectives, and really makes me think, has made me think, well, you know, think and challenge and disrupt, I guess, what I might be offering or what might be useful to that person, that whānau, that unit. It sort of helps me to think through what might have been a disconnect between my practices, my understandings, what I was trying to offer, which might not be acceptable or interesting or needed by some other people. So some other tools that I found useful to think in this kind of space, I guess recognising that a view on health is different. So thinking about te whare tapawhā, and rather than health being the absence of ill health, but being having the unity and the balance between the different aspects of the physical body, the mental body, spirituality, etc. But also there's some newer processes and strategies that can help our kind of day-to-day work. So if people aren't familiar with them, a group from AUT University predominantly have developed this HUI process to enhance doctor-patient relationships, and then they've extended that to psychology. And that's a really nice framework for thinking about connection and relationship first, and exploring what the patient perspective, whānau perspective, might be on what is required and what is needed. And then they've worked from Mason Jory's te whare tapawhā model of health to extend that into the Meihana model, which looks about at access to quality health services, includes people's experiences of health services, experiences of things like marginalisation and oppression and colonisation. So I think this kind of set of tools and recognising this different philosophy can really has really helped me think about how I go about connecting with people and really exploring what is meaningful and important to them, which might be from quite a different way of understanding the world. There is another set of, there's a set of work being done around understanding disability, and this is the space I'm particularly interested in, using something called post-structural philosophy, post-structural theory. So there's two main men that probably began this work, this thinking, in about the 1970s, Mikhail Foucault and somebody called Deleuze. So they're both French and writing from probably the 1960s and to the 1980s and teaching as well. And something that I really like to think about is one of Foucault's quotes saying that people know what they do. Frequently they know why they do what they do, but what they don't know is what they do does. So it's really recognising that we might, with really beautiful, great intentions, you know, come to our work to do a really great job for the people that we're working with and for. But you know, everything that we do, there'll be something that perhaps we haven't thought of, that there will be some effects that are bigger than what we intended. Sorry, that's my 20-minute marker. So I wanted to introduce you to a little bit of the work that's happening in this space, is looking at challenging some ideas that we may take for granted, and recognising that these ideas have worked into things like our assessment practices, our diagnosis practices, and really, I guess, our emphasis on what we've considered as important, for example, around diagnosis or intervention. So this, Erica Berman has written this book called Deconstructing Developmental Psychology. So looking at the idea that we have that children develop in ages and stages, and that there's a fixed progression along those ages and stages to adult competency. So she looks at the history of the developmental psychology profession and how those ideas came about and gained prominence, and critiques them alongside different ways of understanding child development that might be useful in some situations. There's a book called someone else at AUT called The End of Physiotherapy that traces the history of physiotherapy practice and looks at the context of the world, and what suggests that physiotherapy as a profession might need to expand and change its gaze to be of relevance in the future. There's this publication that looks at person-centered care, so it's focused on looking at working with adults and families in the adult kind of space, but thinks about tinkering. So it's challenging the idea of being an expert, and an expert knowing something in particular. So suggesting that being in tinkering is something that's useful to bring to practice. Tinkering being a continual questioning, a continual uncertainty, bringing humility and doubt, and recognizing that they're really important processes of being a professional. There's this one, revisiting therapy assumptions in children's rehab. So thinking about the intent of therapy, and finding a balance between what we're looking at fixing, looking at enhancing function, looking at the burden that rehab and therapy can place on children, moving away from developmental approaches towards lifespan kind of approaches. Being cautious with how assessment and measures are interpreted and linked with people's day-to-day life kind of experience. There is critiques like this one, where we might assume as a physiotherapist, for example, and there'll be different things that dominate the other allied health and medical kind of professions, but we often assume that walking is a really important goal of therapy. So this paper critiques that and thinks about why has walking come to be considered really important, how has that happened, and what else, how else can we think about that? There's this example of connectivity. So thinking that connections between people, their technologies, their environments, their objects, might have a really important relationship with what happens for them in their day-to-day life, how they evaluate how satisfied they are with their day-to-day life. So connectivity as a way of imagining and looking at potentially assessment and intervention. So moving from an individual to the set of relationships that people have. Thinking and critiquing ideas similar to walking, but around independence. So often, again, we imagine in line with that medical model that independence is a really important goal, whereas it might not be for everybody. And it might be that interdependence, dependence, or interconnectedness, and interconnectedness between people and their things are important. And in relation, again, to some of these ideas that we perhaps have around certain people, certain things being normal, and therefore others being othered or abnormal, thinking about things like shame, which are difficult to consider. But I guess that's the thinking about what our doing that might do inadvertently, and that we might not perhaps explore. So I know before not recently now, but about 10 years ago, when I was working as a physio in child development services, I didn't explore the issue of pain with children with long-term conditions like cerebral palsy, because my role in my mind at that time was around child development and things around walking and mobility, gross motor. But I recognised through doing that research where I spoke with children that a number of them experienced chronic pain, which was of more importance to them than, for example, walking, or something that we should really have been thinking about. And so this is some kind of newer research, but thinking about the consequences for somebody's sense of self on what we might focus on and consider important. There might be some inadvertent consequence to that of people, of their self-esteem, of how they feel about themselves and their bodies, how they trust their bodies. So these are there's a big whirlwind of ideas and things to contemplate and ponder. But really, I guess what I hope that some people will go away with is an awareness that the way we do things does not have to be set in stone. We can do our best to provide the best intervention to a particular people, but recognise that our interventions have a particular history and philosophy behind them. And we can note the assumptions and ideas that and unpack them, problematise them, think what else might be possible, what else might be happening here. So I don't know if people are familiar, but a nice starting point for that might be to go to tvnz.co.nz. And there's a really lovely children's program developed by Attitude TV called Who Cares Steers. And it can help to just provoke people, including children, as well as professionals, to notice our own thinking. So there are a number of other avenues, obviously, to help us notice our own thinking. And I guess really this vein of work is similar to the social kind of political processes that are happening in terms of raising the voices, raising the presence of bigger picture issues for disabled people. So there's still the situation that disabled men with intellectual impairment in New Zealand have a life expectancy of about 20 years less than men without. So there's some significant processes happening within our society that mean that those men don't access healthcare in the same way, that extends their life in the same way that others. So there's some things that we can perhaps think about in our day-to-day that we can perhaps critique the way and challenge the way that that we may go about things. So that's it.
Thank you so much, Kate. We have had one comment and question come through, but I did want to just say, like, this very thought-provoking in terms of just the way that our own assumptions are and what we're providing and how we're providing service. And I think it's very timely in this sort of political climate, as well as when there's a really big amount of change happening as well. I'm just going to hand over. Estelle, did you want to just read out? I think it was just got the one question.
Yeah, happy to have a look at that. So one in the chat function there, we've got Karen's noted, I think we have a better understanding of moving away from the biomedical model, but how do we support our work, infrastructure, politics, fund holders to move away from this model? If our work is so biomedical, it can create conflict when trying to not work in this way. How do we support overall shift in thoughts?
Well, I think that's a very great question.
It's a great question, isn't it, Karen? That's a great question.
I mean, I guess that question is really around how do we promote or provoke social change, really. And I think there's no one way. It's, there's the personal level. I can think about my thinking and change my thinking. Then that will come into a bit of a conflict or a clash with your probably your service and where you're working. So that you might have opportunities within your service to say, what are we doing here? Is this what we want to be doing? Is there something else we could be doing alongside instead? How can we go about that? I also think that as professions, perhaps we can become stronger at, at being a part of advocacy, for example. We, in our work, really are aware of what happens for people in their day-to-day kind of lives. And so perhaps we can use our voice to amplify or give a space to other people's voices that aren't often heard. I think there are some really amazing kind of learning opportunities in terms of really noticing that biomedical model and what that does. There's some Dave Nichols, who is one of my PhD supervisors, is great at writing and quite easy to, not necessarily easy to read, but more readable than some of the other people that work in this kind of space. And I think the first step is probably helping other people notice that, and that recognition and holding it within yourself that actually things always change. So the biomedical model came into being, it is still here, it will still be here, but there will be shifts and responses to those models. So the social model is a response to that model. These other newer models are responses, and there will keep being responses. There will keep being shifts and swings and roundabouts. But I think that drawing people's attention back to, sometimes we can become so focused on what on this is what I'm doing and this is what my work is. It's just that reminding ourselves and other people to bring back a broader gaze to what's happening in the world, what's happening in my town, my city. There's opportunities, I think, for people to work in kind of local political kind of structures. So things like the council, things like neighbourhoods, community groups. It could be at your library that you actually notice that the library probably actually is quite accessible, but there'll be a number of just even physical spaces that we use every day that are inaccessible. That could be a starting point to make change.
Thank you so much, Kate, and thank you for sharing your passion with us. There's a couple of comments on chat that people probably have seen around the Enabling Good Lives approach and also transdisciplinary working models with strong client-centered, family-driven goal setting, important steps as well. So I just really want to thank you, Kate, for sharing your expertise and your learnings in this area, and for also sharing the great resources as well. I think that there was a lot of very great articles and reading material that people can be directed to. So thank you for that.
That's all right. I'm very happy if anybody wants to contact me directly. I'm really happy to have a conversation or chat with people in different ways. There's also, if people are particularly interested, there's a really nice paper here at AUT called Disability and Health, which helps people on your own work through the different models and what that means for you, what that has meant for your kind of workplace and your work setting, and then shift to what you think that you might be able to do to create change. So, yeah.
Well, thanks again. Thank you, everybody, for attending. We've reached the end of our session. Next session is in June, 8th of June. Look for the flyer coming out. We look forward to seeing you all again then. Thank you.
Thanks, everybody.